I'm going to discuss with you, and this is a broad overview of all the possible applications of radiosurgery. So we are going to go through many different topics. I'm going to spend most of the time discussing trigeminal neuralgia because that's the most common application of functional radiosurgery. But we are going to discuss a little bit of cluster. After going through pain, we are going to discuss epilepsy, later movement disorders, psychosurgery was radiosurgery, other cranial nerves applications in mimicking what we are able to do with the trigeminal nerve, and finally some spine applications. We just want to discuss that timing is still a big issue. We don't have these patients. We need them to be referred from the neurologist, and it seems that they come a little bit too late for procedures. And then we're going to go through some summary results and discussion about the nuances between the different radiosurgery protocols. So medical management is the first line of treatment, but the reality is that 25% of these patients fail medications at first, and over time they require increased doses or they get elderly, they cannot beat the side effects of the medications, and overall 50% of these patients will end up needing some kind of surgical approach to their pain. And as we know, this is the most common neuralgia with an incidence of 40 patients every 100,000 in the population. So there are many different surgical approaches. Microvascular decompression is the gold standard, long-term results, excellent outcomes, and very little facial hypoesthesia. The only dark side of it is that in experienced hands, the morbid mortality is extremely low, but still there is a risk of more prominent complications such as stroke or deafness. CSF leak is not as malignant, can be managed, or meningitis, but some of the complications may be important. Glycerol injection is the one that shows more recurrence among all the minimally invasive ones. Radiofrequency rhizotomy allows you to be selective towards the rootlets according to the distance of the clivus that you do the frequency lesion. And balloon compression, that's non-selective towards the rootlets. And radiosurgery that can be targeted at different places in the trigeminal pathway, and we are going to discuss why people do it differently and what they find. So when to indicate a surgical procedure, every single paper says that the patient had refractory trigeminal neuralgia, but there is no criteria defining what's a refractory trigeminal neuralgia. For major depression, it's failure of 4 different SSIs plus psychosurgery plus psychotherapy, but for trigeminal neuralgia, there is a lack of this definition, and it's pretty much when they were sent to us. And a review paper on MVD patients on quality of life showed that the absolutely majority of the patients would prefer to have had surgery earlier in their lives. So this picture is very famous. It's the very first patient in the world that was treated with radiosurgery, and this is the fancy radiosurgery equipment. So it was an orthovoltage X-ray tube attached to the Lexel frame. And this patient was treated for trigeminal neuralgia in 51 by Lexel. She had follow-up to 17 years, and she didn't have pain recurrence. The second patient had 22 years follow-up, also didn't have pain recurrence. But even though overall throughout his life, Lexel treated 63 cases, he wasn't very convinced whether radiosurgery was a useful tool or not. And the fact is that once the only way to treat at that time was to inject a mixture of tantalum powder plus glycerol to visualize the nerve with X-ray and then focus radiation the following day. What happened is that when he came to the other day to do radiosurgery in the ward, they were all pain-free because of the glycerol, and that's how they discovered the glycerol. So radiosurgery kind of was left aside throughout the 60s and 70s, and it came back to life because imaging became much better, like CT sequences, MRI thin cuts, and the CT era brought it back because then it was possible to do radiosurgery, not at the Gasserian ganglia, but closer to where microvascular decompression is performed at the root and rhizome. So we did review the impact of radiosurgery in the management of trigeminal neuralgia. And this is just a brief summary showing that at short term, you can expect about 89 to 95% of pain relief. There is a recurrence rate going around 25%. Facial numbness is one of the variables that varies the most from series all the way down from 2% to 50% in our series and in Pollock series. So highly depending on how you evaluate, how the scrutiny of your follow-up, etc. And also there is some relationship with the dose that you apply and where you target, and we're going to discuss this a little bit more. So this is pretty much the algorithm that we use for defining whether a patient should have radiosurgery. So the drawback of the technique is that it doesn't provide immediate relief of the pain. Therefore, it's usually about 6 weeks. Therefore, patients in acute pain attack are not suitable for this. There is no discussion that microvascular decompression provides better results than any of the other minimally invasive techniques, including radiosurgery. So patients who are fit to surgery should have it. But once there is failure of MVD, or patients who are unsuitable for surgery, or they refuse surgery, then and they are not under acute pain attack, they are good candidates for radiosurgery. Now, surgery refusal, it's actually, because we are doing frameless radiosurgery, we have been observing a trend that more patients want to try this first, even though they are blunt. We tell them very clearly that the results are not as good because it doesn't require anything, not even the frame placement anymore. So we may see some shifting over patients over time. Now, the main problem with this is define elderly patients. So there are papers in the literature showing that actually patients over 65 show way more complications, therefore they should be treated primarily with radiosurgery. But there are other series, both retrospective, using 65 years as cutoff, showing that there is actually no difference. So most likely, this means that patient selection is the most important key factor and not age per se, and obviously the surgeon's experience on providing microvascular decompression. But everybody would be pretty much in agreement that a patient who is 102 years old is more candidate for radiosurgery instead of MVD, and that was the case. I think it's the oldest patient that was treated with trigeminal neuralgia, and Antonio treated this patient in France a few years ago. So where to place the isocenter? This is the controversy. So we use this approach at the root entry zone. Some other groups use the far cisternal approach. And we know that for trigeminal nerve, the root entry zone lies between 3 and 4 millimeters outside the brainstem. So here are just some examples of groups using different targets, from closer to the pons to the mid-cisternal segment to very anterior, and mostly in Europe they use this approach. This is the kind of imaging we get in our patients using T-cuts and C-sequence. You can pretty much see everything, and here are the different positions of the isocenter. But that's what we currently use the root entry zone with the 50% isodose touching the pons. But it wasn't like this since the beginning. The beginning was really careful with the 20%, so more towards the mid-cisternal approach. Because of the results I'm going to discuss with you, the isocenter was moved towards the pons, and this is our current isocenter placement. And what did we see when we compared these 3 approaches using the same dose for all the patients? There is indeed an increase in the facial numbness incidence as you bring a higher dose closer to the root entry zone and to the pontine surface. And the risk difference is about 20%. Now, what about the other aspect? We know we trigger more facial numbness, but what does happen with the pain? And this is our publication in this series. Majority of these patients actually had idiopathic or essential or classic according to the International Headache Society or Burkill type 1. You choose which name you want to give to it, but everybody knows what I'm talking about. So obviously this is not a randomized study, and that's what we were lacking. The follow-up time is shorter for the last group because it's the most recent one, but you can see a trend to better pain relief as we move the isocenter closer to the root entry zone. The time to relief also seemed to decrease, recurrence decreased, and numbness increased. But the level of numbness did not get worse. We do rate our numbness from 0 to 5, with 0 no numbness and 5 very important numbness, anesthesia. So 2 is in between mild to moderate numbness, and that's usually the degree of numbness we see. Even though in our series we do observe about 18% of more important facial numbness that they describe as grade 4 or 5. So our results, excellent, we mean pain-free, medication-free. This is the gold standard. And good, they have more than 90% of pain relief, but require some use of medication. And this would be pretty much the BNI 1 to 3B. That's another classification used for pain relief. So pretty good at 1 year, and at 3 years about 65%. And this is what radiosurgery can do. This is among one of the best results in the literature. Now this is the overall series, and here we just compare to the initial 60 patients that were treated. So we are doing better. We are getting more pain relief as we brought it close to the brainstem. So we know that as radiosurgery for TriGem works, but how does it work? Unfortunately, to date, there is only one experimental study performed in baboons, and 2 nerves were irradiated with 100 gray and showed completely necrosis. That's not what we want to cause, because we may trigger deafferentation pain, what's way worse than the problem we are trying to solve. 80 gray showed some level of damage to the nerve, but not complete nerve damage, really focused to the area and no damage nearby. They didn't see any specificity towards the type of fibers, but there were only 2 nerves, so it doesn't mean much. And the problems with this study is that these animals were just normal animals, so we didn't have a real trigeminal neuralgia nerve with those areas of demyelination for us to evaluate the effects of radiation on that. But why did we choose to use the root entry zone? Other studies showed, and it's well known, that the central myelin is more sensitive to anything, to vascular compression and to radiation. And so it makes sense to target radiation to a spot where you can get more results or more effect from the same dose. And that's the rationale why we brought it closer, as we felt that it would be safe. But how we think about it, when we deliver the radiation to the nerve, when it's close to the root entry zone, we are actually delivering a higher dose of radiation to the sensory nucleus that is at the same level in the brainstem. And we know that the nucleus that controls for pain is down there. It's the caudate portion of the spinal nucleus, which is receiving a lower dose. There is no consensus on why trigeminal neuralgia occurs. There is pretty much a combined hypothesis from peripheral and central causes that the demyelination in those little spots in the nerve peripherally would induce neuroplasticity in the brainstem and completely remodeling of the thalamic pathways for pain recognition. So there would be an increased perception of the sensitive information that's triggered by the small areas of demyelination. And then we know that radiation blocks that conduction, and our goal is to block the conduction where the demyelination happens, that's in the root entry zone. But we are actually able to trigger more pain control and earlier than we trigger hypoesthesia and in a delayed fashion. And if we think a little bit outside the box and look at a very unusual dose distribution, because here what I put is the very low isodose lines, 1%, 2%. The dose to the nucleus of the trigem, they are really minimal. It's about 1.8 gray to the principalis and 0.9 gray to the caudalis. Whether or not these doses may be able to generate some kind of modulation on the upward conduction of increased sensory stimuli, it is still to be proven or to be seen, but we need to think about it too. It's not just to think that we are burning the nerve and that's it. So here's the coronal view of it. And the first time we actually saw this image in clinic, we were very scared and concerned about it, but the patient was doing just fine, pain-free, med-free, very happy, mild numbness. And we followed up all patients as much as we could with MRI images. And what we did see is that these patients who present this kind of enhancement, they do better in their follow-up. Obviously, the first confirmation is that we actually hit the target with our radiosurgery. We did what we were intending to do. And this, even though it's impressive, does not translate into a very clinical, important feature in terms of complications. So other papers in this line show that actually as you bring the isocenter closer to the brainstem or you deliver the higher dose to the root entry zone and to the pons, these are predictive factors for success, or a longer cisternal nerve segment goes against better. It's more related to failures than to successful outcomes. And even the trial comparing two isocenters, increasing the length of the nerve for irradiation showed more complications, but lack of benefit. And the same was seen with the CyberKnife, because they used the node instead of they are non-isocentric radiosurgery. They vary the length of irradiation of the nerve from 6 to 13 millimeters. And they did get serious complications, and they didn't show as good results in terms of pain relief. So giving more dose or increasing the length of the nerve submitted to the same dose does not help, which again suggests that we are doing something else more than just burning a portion of the nerve. So this is the Kaplan-Meier of the probability of enhancement if you order follow-up MRI scans for all these patients, and it's pretty much 48.8% at 1 year radiosurgery. So it's rather common than uncommon to see that. And these patients, they are the winners. Inside our series, in our cohort, they actually do better if they present this enhancement, but at the cost of more facial numbness. Now, what about the time course for this enhancement? Is it permanent? Does it imply this is a lesion? Are we in the brainstem or not? And we did select only the patients who had at least multiple MRI follow-ups. And as you can see, this enhancement does subside over time, almost unnoticeable here at 21 months. And it follows pretty much the radiation curve expected after irradiation of any other lesion, as an AVM or a tumor, etc. So it does subside, but it's showing to us that we are really hitting the sweet spot for that. And this is the classical case, the case everybody wants to treat with trigeminal neuralgia. Elderly lady, she presented this kind of reaction. She was pain-free 1 month later, had very, very mild numbness, 1 out of 5. And even though this is predictive of a successful outcome, it is still not a unquestionable measure, because if you look at this MRI scan, it's pretty much identical to that one. Another elderly lady with prior procedures, but this one, she developed complete corneal anesthesia and facial anesthesia. We did give her a Medrol pack, and she improved over time, even though she still has a deep hypoesthesia in her face. So pretty much unpredictable how it's gonna respond. We have discussed then the position of the isocenter and what is the rationale of bringing it closer to the brainstem. What about dose? When we looked in our series, those who were irradiated in the beginning with less than 90 gray versus 90 gray, the higher dose group did better in regard to pain relief, showed less recurrence, and we didn't see more complications. So we decided to keep the protocol at 90 gray. Majority of the centers prescribed from 80 to 90. We know from the very first modern study in the radiosurgery era that less than 70 is not good, not too many patients respond, and high recurrence rates, and 100 gray from the baboon studies, it's too much. So pretty much the window is between 80 and 90. This is our current protocol, and we use 7 no-coplanar arcs equally distributed. And now with the Novalis TX, we can have, because the machine has a higher output, we can treat only with 1 pass per arc, what is about 30 minutes treatment time. And that's one of the fastest treatment times available. It's actually the fastest machine for that sake. And that becomes also important because it's very challenging. You are treating a 3 millimeter structure with a 4 millimeter collimator. And even though there is all the precision for correction and stereotaxis, you have to think this nerve is kind of flotating in the CSF cistern. There is some respiratory movement that you can't keep track of it. So if you, and plus the patient movement itself, even if with the stereotatic frame or without. So faster you can treat, more likely you are delivering as much dose as you want to that precise point. So just to show again our current protocol, and the 50% is this green line here. So the major drawback of this technique is the period that it requires to trigger pain relief. That's in average about 6 weeks. But we did notice that some patients do present with immediate response. They leave radiation oncology, and 1-2 days later, they are completely pain-free. So we had 2 questions. First of all, is this real or is this placebo? And if it's real, which are the predictor factors that we can then improve our protocol? And we look at it on 150 patients. Out of them, 20% presented with immediate pain relief. So it's relatively rare to occur. For those patients who didn't have immediate pain relief but did have response, the mean time to good and excellent outcomes was 2.5 and 3 months. And so this is pretty much the questionnaire we use, and that's how we keep track of whether or not they presented with immediate. That's defined as 48 hours to achieve pain sensation. And our hypothesis was that a higher dose to the brain stem, and that would, even though you're using the same protocol, depending on the angle of the nerve at the pons, this area here would receive a higher dose or not, and that would offer the anatomical substrate to our hypothesis, would be the explanation, and you would see this difference in this series. So here's pretty much just showing a dose distribution, and what we did see is that, somewhat to our surprise, is that the patients who have immediate pain relief, they not only benefit from having immediate relief, but they also have longer lasting pain relief in comparison to those that are successfully treated, but they take a little, like the 6 weeks to improve, to respond. And this is true for excellent, and this is true for excellent and good pain outcomes. However, the recurrence rates were pretty much similar in both groups. And I know someone is going to ask, well, if one does better than the other, how come they have the same recurrence? That's based on our definition of recurrence. We define recurrence as any drop from the best level of pain relief ever achieved, which means a patient is out of medication, out of pain, and then suddenly he requires a little bit of medication to be out of pain. It's a recurrence for us. But is it still a good outcome? Some other authors, like Pollack, they define recurrence as failure requiring additional surgical procedures. So it varies in the literature, so be careful when you read and how you interpret the findings. And what about failure? After radiosurgery, can you repeat? Is it successful? Is it too dangerous? And many series now in the literature, this is the largest 112 patients treated for the second time with radiosurgery. And all of them, some protocols, they give the same dose to the same spot. That's our policy. Some other people, they give half of the dose to the same target. And some other groups would move the isocenter anterior and deliver the same dose. But from all these different recipes, what you can see is that you should still expect about 80% pain relief, but more numbness incidence overall. And those who already have numbness, they develop deeper numbness. But it shows that it can be used. And since July 2009, we have been using frameless radiosurgery here, because we do have the TX machine. And with that, now we are over probably around 50 patients treated so far. And we and the Kaiser here in LA are the only centers doing frameless radiosurgery for trigeminal neuralgia. It does require a lot of checks, and I'm not going to go in detail on that. So trigeminal is done. Now I'm going to move faster throughout all the other indications. Cluster headache. So this paper here showed very easy statistics to understand. Do radiosurgery in the trigeminal nerve to improve cluster headache does not work. Out of 10 patients, 10 failures. So don't think about it. Now this phenolpalatine seems to be a feasible target. And our policy here is to do a block with the steroids for this phenolpalatine. And if the patient responds, then we can do radiosurgery. There are other papers with a very impressive title saying that it may work, but it doesn't work with the trigem. And here we publish a technical paper on how to do this. It does have some good results for cluster headaches in this phenolpalatine. Now moving to epilepsy, what about hypothalamic hamartomas? And I'm not going to discuss here whether radiosurgery is better or not than surgery. And surgery can be a skull-based approach, a transcallosal approach, endoscopic approach. The fact is, it seems, at least from the most recent series published from Arizona, that surgery leads to the best outcomes in terms of seizure-free. And an experienced hands has acceptable levels of complications. Now, when radiosurgery could be applied, and if, and so this is the question I want to focus, and it's still not clear, and what it would be the dose. So that's pretty much a classical imaging from hypothalamic hamartoma, hypo to iso intense. We have treated very few cases, only 5 cases to date. And here is an example of a boy that already had epileptic encephalopathy, so he already had range attacks, aggressiveness, and we did treat him with 18 gray. This little girl here presented with seizures since she was 2 years old. And the important thing about this, because of the eloquency of the target, the fall off of the dose has to be inside the lesion. We don't need to give margin because this is not really a tumor. We don't need to encompass and be sure that we get the whole thing. And that's so. Which are the key points in discussion? Should we treat them earlier or wait until they are a little bit older? There is a trend to treat as early as possible to avoid the development of encephalopathy. But is radiosurgery better because it doesn't incur in the acute complications that you can see with surgery, or the hormonal deficits that one should expect from irradiating this area in young children will overcome the possible acute complications? So we don't know all these answers. Now, obviously, the severity of the neurological deficits dictates if you have a child that's very impaired, then if you damage a little bit the fornix, are you really be able to notice that clinically? And it will be relevant to the entire picture. But if you have a young child, not very compromised, Should you try to disrupt everything and stop the seizure so she doesn't develop encephalopathy? Or should you wait and deliver radiation, which will require a latency time to achieve seizure control? And then you are running the risk that she develops encephalopathy until you achieve seizure control. So these are the key questions unanswered in the literature. And medication management once seizure cessation is accomplished. And then the anatomical classification. So as you can see here, out of our publication, everybody has very, very few experience. So the largest series, 8 cases. And actually the largest series currently in the literature is from Marseille, from Jean Regi, and he has 27 patients with more than 3 years follow-up. Now, he shows that about 60% of the patients are much improved, with 40% of them being completely seizure-free. And he didn't notice any important permanent neurological deficits, showing that it is safe and is effective if you compare to the surgical series, even though the surgical series suggests that it's slightly higher seizure-free rate. And this is what he recommends. So a little bit maybe twisted towards radiosurgery, but that's kind of how he sees the question. And he is the most experienced radiosurgeon for this indication. Now, this is another view from a surgical group from Arizona, and they operated on 165 patients, and they basically see radiosurgery for small lesions and used in conjunction to different surgical approaches. So it's still not clear. Now, this paper here actually did a very nice follow-up on all these cases, and they did something different. They irradiated the full hamartoma, as I showed to you, in 6 cases, and they attempt to do a disconnection in 3 cases. But unfortunately, they fail in all 3 cases. And that shows, because that was an idea going on, maybe you decrease the volume, you are safer, even though you are still irradiating where you don't want to be, that's closest to the hypothalamus, but maybe you can increase the dose and trigger seizure control earlier than 7 to 9 months, but it doesn't work. And here's an example. Now, this is one case that I want to illustrate how we don't know very well how to manage still these patients. This lady here, she had a radiosurgery, and this is her seizure diary summary. We did treat her with 15 gray, and 7 months later she was seizure-free, and almost after 5 years later the neurologist decided to remove the medication, which seems pretty reasonable. She had EEG, all these studies. Once he removed, she recurred, and we did repeat radiosurgery for her. So we also don't know, can we repeat, is it safe, which are the outcomes? So many unknowns. And here's just to show this study where the progression of the seizure comes from. And as you can see, it really does start in the interface between the hypothalamic hamartoma and the hypothalamus, because a safer approach would be to try to spare this area here and irradiate the rest, but it doesn't mean that it's going to work as well. And what about mesial temporal lobe epilepsy? So if we want to offer radiosurgery for these patients, the minimum should be equal to this. And what does the literature show? So that the series from Marseille, again, they have a very strong epilepsy group there and a strong radiosurgery program. And they actually show that, yes, you can achieve about 65% of patients being seizure-free without major complications and permanent neurological deficits. That prompted the multicentric study here in the United States. And they did 2 doses, the low, considered low, 20 gray and 24, and the results are really impressive. So, and obviously more seizure control in the group receiving higher dose. The problem is, in both groups, more than half of the patients needed to receive long-term steroids. So we are not doing any better with radiosurgery. We can achieve the same degree of seizure control, but everybody knows that keeping these patients a year in the steroids is way worse than 2 weeks recovery from a craniotomy. So still we need to think, we know it works, but we need to be more creative and think better how we could decrease possibly the size of the target and decrease toxicity, or not trigger necrosis, because that's why we are seeing this dependence on steroids. It's necrosis. So how can we modulate the function of the cells? Because we can modulate, but in a less toxic way. So it's still to come. Not to say that there was one mortality here, which was not seen in, you don't see in the surgical series as well. So every time we have a trouble with single dose, we fractionate. So what happens if you fractionate in the setting of temporal lobe epilepsy? Doesn't happen. So 37% of the patients responded somewhat, so doesn't work. What about for movement disorders, for tremor and bradykinesia, dyskinesia? So who are the candidates for radiosurgery thalamotomy, and how to control for lesion size? So if you compare this to DBS, which are the disadvantages? First of all, you treat with the same collimator, same dose, but you cannot predict the final size of the lesion, and that you will know only 1 year later. The second thing, you don't have monitoring on where you're going to put your lesion, and it is irreversible. So 3 disadvantages if you compare to DBS. So radiosurgery thalamotomy is pretty much reserved for those who are completely unsuitable to be treated with deep brain stimulation. Here we have treated about 6 patients. Probably now I treated 7 or 8. But at the time of the publication with 140 grafts, and that's the final lesion volume in our series. And I'm going to discuss with you why we moved from the 5 millimeter to the 3 millimeter collimator. I'll show to you our only complication. Even other groups, they have still very small sample size. And if you see the results and compare to what you see with DBS, this is much worse. DBS does much better than 70% of some improvement, and at the cost of almost 10% complication and serious complication. So the largest series published comes from Young. He has treated over almost 200 patients. If you add the Parkinson's disease patients, he has reached that number. His follow-up time pretty much ranges from here. And he does have 81 and 77% of improvement in tremor and writing score. Is still worse than DBS, but the best results in the radiosurgery literature. But the complications, in our opinion, are unacceptable. If you compare 7% complication per lesion, if you compare a 0.5% risk of hemorrhage, that's the most worrisome one for DBS. And in our series, when we reviewed here, we actually have only 0.8% of hemorrhage in our series. So it really does not compare. It's not as good. And the problem was the final size. So patients who presented complication had a final lesion volume 8 times larger than those who didn't show complication. And this study here was actually, in my opinion, is the best radiosurgery paper on thalamotomy. Few cases, only 18. But they did this in Toronto, and they used the same protocol and scrutiny they used to evaluate DBS success. And if you look at the results, now they're much worse. They actually saw only a modest anti-tremor efficacy and only improvement in the activities of daily living. And this was evaluated by a movement disorder neurologist, and he saw pre and post videos that were randomized, so he had no clue whether the patient was pre or post. So that's the real result of radiosurgery thalamotomy, and not the 77 that I evaluate the patients I treated. And so these are important features also when you see the papers to consider. Now this is our complication. 67-year-old gentleman with all these comorbidities, diabetic, cardiac bypass, and he couldn't inject his own insulin, so he was very debilitated. He had mild dementia, cardiac issues. He was on Coumadin, and he had a prostate cancer under remission. So I don't think anybody would be very excited about putting a DBS on him. So we did do the thalamotomy, 140 gray. So doses here are even higher than for the trigeminal. That's the plan. And 5 months later, he was very happy. He barely had any tremor, and he wanted to have thalamotomy to the other side. Obviously, we said no. And 8 months later, he started to develop some kind of apraxia. He didn't have any weakness, and that's his MRI at the time. So you can notice here that something is going on. There is some edema, hypodensity, and that's the contrast enhancing. So this lesion went way above what we were expecting in terms of volume. And this is the images, you know, the flare and the flare in the tissue. Now, 9 months later, he was hemiparetic. And then he was put in steroids, he was diabetic, and all the complications started. He needed the steroids. He ended up being wheelchair bounded. He was transferred to a nursing home. But we know that all radiation effect actually resolves after a year and a half. So at 19 months, this doesn't mean you are causing all this is damage to the tissue. There is some necrosis and some inflammation going on here. But the dimension deteriorated, so that after this case, we now go with the 3mm collimator because it's preferable to have less tremor control, but not to have this kind of complication. But also it prompts the discussion if we should be offering any procedure to this kind of patients, or if they are too sick to take even radiosurgery as an alternative. So pallidotomy, should we use? In just one paper that summarized 33% improvement on symptoms, bradykinesia and dyskinesia, more than 50% complications and serious complications. So pallidotomy with radiosurgery is not an option, shouldn't be performed. And as always, there is someone monitoring what is done. And these neurologists here put together on 8 cases of functional application for movement disorder. And as you can see here, a perfect thalamotomy in the internal capsule. So this is another thing to consider. What about psychosurgery, anterior capsulotomy? The main points to define are where is the target, and that hasn't been completely established from the DBS literature. And once we know the location, what's the optimal size of the lesion? And for this particular indication, everything I mentioned to you as a disadvantage in the movement disorder setting actually becomes an advantage. So we know that from the DBS literature, these patients require their batteries to be changed every 1 year, 1 year and a half. They are young. They are, psychiatric patients. So how do they handle if they go out of battery and they don't follow up, or we miss when to change before it fails? Are they going to become suicidal? It's hard to have this kind of population to have control on when they need the battery and to come for follow-up. The other thing is that they are in a safer position for us. Even if we have unpredictable response from radiation, we are in a more silent area in terms of side effects. We are not in the internal capsule. So we have more room, or the basal ganglia, we have more room to tolerate that. And this is definitive. For this particular population, you may not want a reversible technique. But first, we need to very well establish where is the target. And there is some discrepancy. I believe once the DBS literature established the right target, then we are going to optimize the size of the lesion. This is a mock plan that was done here at UCLA, extending to the base of the anterior capsule. Some other people are just doing pretty much around target, not extending. So this is still needs to be scrutinized. But one of the largest experiences comes from Karolinska. And here, this publication is from the 80s. They were doing radiofrequency and radiosurgery and showed good results with radiosurgery. But if you can judge from the 70s stereotaxis and radiosurgery stereotaxis, this is a good lesion, but this one is pretty much in the pretamine and the same for this one. So they did see in this study that the right side works better. Now you wonder why. But there are more recent papers in the literature, and this is a very nice paper that was actually done in Brazil. And they did evaluate 5 patients and aimed to prove the principle that the frontal basal thalamocortical frontal basal circuitry is involved in the OCD physiopathology. So they did volumetric MRI before radiosurgery and 1 year later, and showed that there is an increase in the volume of the gray matter in the circuitry after radiosurgery. This is the paper from the Pittsburgh. They were able to do 3 patients with OCD treated with radiosurgery, and here they are showing the iBox outcomes. And John Adler in Stanford treated 1 patient. So far in the United States, there are 4 patients treated for OCD with radiosurgery. There are more treated in Europe. And some other publications even expand their use to other mental illness indications, but this has to be carefully done, and I don't think we are ready yet for radiosurgery. What about other cranial nerves? So I'll just breeze through. One would think that hemifacial spasm is an absolute surgical indication, and it is, but there is in the literature an Italian group that actually did single dose, much lower dose, not 90 gray, not 100 gray, and hypofractionation for 3 cases. They didn't see any complications with a very, very limited follow-up time, less than a year, but has been done. Not that we advocate. But a potential elegant use of radiosurgery could be for untreatable tinnitus or vertigo, because we know the 8th nerve is sacrificed in the surgical treatment of this condition. But we still need to figure out a way to identify the facial nerve inside the petrous trajectory in order to preserve it. But possibly it could be an indication if we can improve on that one and just give a blasting dose to that area. What about glossopharyngeal neuralgia? That's the second most palpable indication in terms of pain. We saw for trigem, and for glossopharyngeal neuralgia, this case was treated with gamma knife, took 3 months to have some pain improvement, and pain recurred at 6 months, but at a less intense and frequent attack. So is this real? Is it placebo? It's one case. And if you look at the literature, there are 3 other cases published, so we don't have enough data to define whether this may be used or not. But if we pursue this indication, and I think it's reasonable to try, we have to beat this kind of results from large series of microvascular decompression. And I'll just finalize with the spine pain indications. This is a experimental study in the pig performed here at UCLA. And the idea was to see if we were able to target the ganglia, the sensitive ganglia, with radiosurgery. And as you can see here in the follow-up, 8 months later, well, that's the red circle over there, there is edema in the area showing that we really hit it. And the neurological exam also showed that these pigs were hypostatic in the area. And the blue toluidine stain showed some damage, similar to the one we saw in the picture from the baboon studying the trigeminal nerve. So we are just repeating in the spine what we were able to achieve with the trigeminal nerve. In the literature, there is only this paper showing with less than 1 year follow-up in 5 patients, just showing no toxicities at short-term follow-up, but it's a potential application of radiosurgery. We did treat 1 patient, but that was for untreatable pruritus. And this lady had a drop metastasis from esthesioneuroblastoma, and it did help her. But basically, in conclusion, as we understand better how radiation can be used to modulate and not to destroy brain function, it seems that this area of neurosurgery is very, very promising. Thank you.